Welcome to NAPLEX 101. Okay, so today we are going to talk about heart failure. So what is heart failure? It's a reduced cardiac output. How do you reduce the cardiac output? You either impair the filling or impair the ejection. Or both. Impaired filling, impaired ejection, which reduces cardiac output. There's two types of heart failure. There's diastolic and systolic. Systolic is HF-ref, or reduced ejection fraction, where diastolic is HF-pef, preserved ejection fraction. That ejection fraction usually it's considered reduced at 40%. Average for good healthy human is 60%. Then there's the etiology of heart failure. There's ischemic and non-ischemic. Ischemic is if you've had a heart attack, an MI, or severe CAD, coronary artery disease. Now, non-ischemic is everything else: uncontrolled hypertension, pericardium cardiomyopathy, viral diseases, thyroid diseases, things like that. So basically, ischemic is MI, CAD, whereas non-ischemic is everything else. Now let's talk about the pathophysiology. So we've got the sympathetic nervous system, and we've got RAS, renin, angiotensin, aldosterone system. So these are the compensatory responses. So what does that mean? The body realizes the cardiac output is decreased or reduced, so then these systems are activated. So norepinephrine is released from this SNS, which increases heart rate and contractility of the heart. And then renal hypoperfusion occurs when RAS is activated. So angiotensin 2 and aldosterone increase in concentration, which increases the afterload. Norepinephrine and angiotensin 2 increase the afterload, whereas aldosterone increases the preload. Now, that works great for like a couple months, I guess, however long it takes to remodel a heart. But it increases cardiac output, but eventually there's ventricular remodeling and hypertrophy, so the thickening of the wall of the heart, so that decreases cardiac output. Therefore, the compensatory mechanisms don't work. Presentation. So these patients present with usually fluid overload, volume overload, and decreased cardiac output. This can be seen using pulmonary congestion or peripheral congestion. So you can hear crackles in their lungs. They could have shortness of breath, dyspnea on exertion, or they could have bilateral 2+ pitting edema. They also weight changes, which goes along with the edema, nausea, vomiting, and then they can also have worsening of renal function, but no one really knows when their renal function is worsening. But it's a lab value. So diagnosis is usually a diagnosis of patient's symptoms. So they have fluid retention, dyspnea on exertion, decreased exercise tolerance. Then you can also get lab values like a BNP, super high BNP, heart failure. It's more of a disease of risk out because other things can elevate a BNP, such as a PE, something like that. And you can also get an echo to get an actual picture of the heart and see the ejection fraction. So there's two different kinds of staging/classifications of heart failure. There's the ACC/ADA, which does A through D, and then there's the NYHA, which does 1 through 4. So I think of ACC/ADA, begins with an A, so has the letters, it's more symptom related. So A is risk of heart failure, B is asymptomatic heart failure, C is signs and symptoms of heart failure, D is end-stage heart failure despite maximum therapy on medicine. So then the NYHA is 1 through 4, it's more clinical, so no symptoms, 2 through 3 has symptoms with mild or moderate activity, and then 4 is symptoms at rest. So NYHA is symptoms, whereas ADA, ACCA is more of like structural. So what are preventions for heart failure? So for stage A, when a patient is at risk for heart failure but doesn't have it yet, you manage comorbidities, so like hyperlipidemia, hypertension, coronary artery disease, all that fun stuff. Now, if they are in stage B, which means they have signs and symptoms, they're asymptomatic heart failure, they need to start being on meds so we can prevent that remodeling and the hypertrophy of the ventricular muscle. So we would use beta blockers and an ACE inhibitor. And if they can't tolerate an ACE inhibitor, ARB. So now we're going to go through all the drugs. It'll be short, sweet, to the point. Treatments. Loop diuretics. So this is your furosemide, bumetanide, torsemide, ethacrynic acid. They block sodium reabsorption in the ascending loop of Henle. Ascending loop of Henle. They provide symptom relief of volume overload, improved exercise intolerance, and prevents hospitalizations, but has no impact on mortality. One thing you might know is that you can develop tolerance to loop diuretics, so you can add a thiazide or increase the dose. There's not really a max dose of furosemide. Side effects, you need to watch out for your electrolyte imbalances, so your hypokalemia, hypomagnesemia. You can get hypotension as a blood pressure medication, and renal dysfunction. Note that, because they could have an AKI. Now we have ACE inhibitors. We just talked about loops. Now we're going to ACE inhibitors. So it prevents the conversion of angiotensin 1 to angiotensin 2, which would increase the angiotensin 1 increases afterload, remember. So we're stopping this compensatory mechanism. And ACE inhibitors show reduction in mortality, progression of heart failure, hospitalizations, and improvement of symptoms. So like gold. ACE inhibitors are gold. Some side effects, hypotension, hyperkalemia, renal dysfunction again, and then cough and angioedema. Contraindications, angioedema. You want to breathe. Bilateral renal artery stenosis, and then pregnancy. ARBs inhibit angiotensin 2 receptors, side effects, renal dysfunction, hyperkalemia, and hypotension. Only use an ARB if you can't use an ACE. You know, the bradykinin break-in causes the cough. Increase in bradykinin because it can't get deleted. Can't get metabolized or whatever. So you get that cough, so you can go to an ARB. But ARBs don't show that mortality benefit that ACEs do. Beta blockers show improvement in mortality. And then the beta blockers for heart failure are bisoprolol, carvedilol, and metoprolol succinate. Specifically succinate, you need the extended release. You don't want those peaks. You want a steady curve. Side effects, hypotension, bradycardia, fluid retention, fatigue. But fatigue goes away in about 2 weeks and it recalibrates and they feel better. For patients with COPD, diabetes, asthma, and peripheral vascular disease, it's best to use bisoprolol or metoprolol. Those are the cardioselective ones. Now let's move on to I can't ever say this one. Naproxen and an ARB together. So naproxen degrades the natriuretic peptides and other circulating media is responsible for the counteracting compensatory neurohormonal response. It shows when compared to ACE inhibitors, it has reduced mortality, hospitalizations, and symptoms. So this is pretty good, but you only use it when an ACE inhibitor and a beta blocker are not working well. So if a patient is on a beta blocker and ACE inhibitor, still having symptoms of heart failure, you can switch it out to naproxen and an ARB. It's important to know that you need a 36-hour washout period between an ARB and starting this BNP degrader. Aldosterone antagonists, these are very good for HFpEF preserved. A lot of the clinical trials are for HFrEF. So HFpEF aldosterone antagonists are pretty good for hospitalizations in HFpEF. They inhibit the aldosterone receptor. There's reductions in mortality and hospitalizations, but it's important to note that you need to monitor kidney function and potassium. Potassium has to be less than 5, and creatinine clearance must be greater than 30. Now we've got isosorbide dinitrate and hydralazine. ICDN is a vasodilator, whereas hydralazine is an arterial vasodilator. They work well. They're good for, they just have, like, we know about the tolerance that occurs with nitrates. So it has to be taken twice a day, or you need a washout period. This is important, using it in African Americans when symptoms are still present despite being on an ACE and a beta blocker. Important. So you can use hydralazine and nitrates for African Americans that are not doing well on ACE and beta blockers. Side effects: dizziness, headache, typical vasodilator things. Now we've got ivabradine. 2 more. This is the last one more to go after this. It inhibits the IF current in the SA node, leading to reduction in heart rate without the effect of the contractility. It's 7.5 milligrams twice a day to keep a heart rate between 50 and 60. So if you're on beta blocker therapy and you can't get your heart rate down, this is the drug you can use. Finally, digoxin. Digoxin is a neurohormone modulating that affects heart failure. It improves symptoms and reduces hospitalizations. You need to note that dose reductions are needed in patients that are older, renal impaired, or have a low body weight. Side effects include bradycardia, altered mental status, GI upset, and visual disturbances. You can see those halos. Remember, like, Van Gogh? They thought Van Gogh, yeah, anyway. But that's heart failure. Next on the list is acute decompensated heart failure. So we'll be going over some inotropes and fun things like that. Catch you next time.